Solitary pulmonary nodules. Solitary pulmonary nodules are defined radiologically as solitary nodules of lung less than 30 mm in diameter, fully surrounded by aerated lung, and do not have associated features such as atelectasis, adenopathy, or effusion. These are found incidentally on imaging performed for other reasons as screening exams or due to symptoms of the other conditions. 95% of the nodules in this study are benign and highlighting the importance of reliable diagnostic modalities to identify those lesions at highest risk. Recommendation for management and follow-up of SNP varies between those found on screening and those found incidentally. The Fleshner Society is an international radiological consortium, publishes evidence of guidelines for the management and follow-up in the incidental SPNs, and distinction is made between the solid and subsolid nodules as well as low risk and high risk patient. These guidelines do not apply to the patient with extrathoracic malignancies who are at the risk of pulmonary metastasis. The initial evaluation begins through a history of physical examination to evaluate the risk factor for malignancies such as advanced age, family history, immunosuppression, tobacco use, and greater than 100 cigarettes in lifetime is considered as a risk factor for malignancy. The next comparison is made prior to imaging studies to evaluate the change and the growth of lesion. Stability for more than 2 years or imaging is associated with a very low risk of malignancy. Conversely, the SNP that increases the size should raise the index of suspicion for cancer. Several modalities have attempted to predict the risk for malignancy for SPNs. The most extensively validated model was developed by Mayo Clinic and take into account age, smoking history, history of extrathoracic cancer, radiological features, and of the nodule diameter, appearance, and location. Although the prediction models are helpful, they are imperfect, and clinical judgment thus remain an important part of the evaluation. Symptoms of cough, hemoptysis, chest pain, weight loss may be important clues for the risk of malignancy, and nodules found incidentally in symptomatic patients are most likely to have been present for a longer duration but less invasive to have a better prognosis. So the size of the nodule, the size and growth and history of SNPs are most important determinants in the malignant potential. Nodules of less than 6 millimeters have less than 1% risk of malignancy and therefore do not require the routine follow-up in the low-risk patient. Conversely, the most lesions of more than 3 centimeters are malignant. Analysis of multiple large series demonstrated that the risk of malignancy correlates strongly with nodule size. 0 to 1% for nodules of less than 0.5 centimeter in size, and 60 to 28% for nodules of 0.5 to 1 centimeter in size, and 64 to 82% for nodules of greater than 2 centimeter in size. Location: the primary lung cancers have upper lobe predilection, and therefore the upper lobe nodules are considered to be higher risk, and converse is due to metastatic disease, and which tend to occur in the lobes due to the relative increase in the lobe blood flow and hematogenous spread. Expansion of the multiple centrally located nodules associated with bronchoscopic bundle and sarcoidosis, hypersensitivity, pneumonitis, and other bronchocentric processes that are often uniform. Irregular nodules randomly distributed throughout the lung are more characteristic of metastatic disease. Growth is the hallmark of underlying malignancy, although meaning the doubling time of 149 days for solid cancer. Change in size may be detected as little as 1 month or rapidly growing tumors and may take over more than a year for a slower growing cancer and extremely rapid growth over the days or weeks is more characteristic of infection or inflammatory process. However, the slow growing infection lesions may be caused by the mycobacteria or fungal infection such as histoplasmosis and are differential for enlarging SNPs. Empiric anti-infection treatment for these entities may be given appropriate clinical circumstances while continuing the serial imaging nodule growth while on the treatment of TB generally exclude TB from differential while most nodules stable for 2 years are considered benign for a longer period of surveillance and warranted for ground grass opacities and which can represent adenocarcinoma in situ. The imaging studies, particularly CT scans, however, show multiple nodules and the presence of multiple nodules can be helpful in diagnosis and usually suggest the infection, past scanning and metastasis spread from the extrathoracic malignancy. The metastasis appears homogeneous in morphology and heterogeneous in size, and the calcification is most reliable morphologic features of benign lesion, especially uniformly distributed throughout the nodule. Radiologically, the visible calcified tissue generally develops in the time span that is incompatible with the neoplastic growth, and exception occurs with the growing cancer and push aside and calcified lesion which makes eccentric calcification less reliable sign. Hematomas is most common benign lung tumor and have the characteristic appearance of the popcorn lesion and typically seen due to the calcification within the lesion. The CT scan identifies these nodules fairly reliably and they are generally 1 to 3 centimeters in size, smooth lobulated and mixed adipose and soft tissue. Stable hematomas should be observed without the surgical intervention. The neoplastic nodules usually have higher borders and often appears speculated, lobulated and CT scan rather than round well circumscribed. Cavitation can occur both in malignant and benign processes. More than a quarter of squamous cell carcinomas have antral cavities. A subtype of SPNs is pure part solid ground glass opacities, and this term refers to radiological densities that are greater than underlying lung parenchymas. Ground glass opacities are common, non-specific, and can result from any material such as edema within the alveoli, and they do sometimes represent a slow-growing malignancy, most commonly the low-grade in situ and minimally invasive adenocarcinomas, and therefore should be followed for a longer period of time and demonstrate stability. The growth size of more than 3 centimeters or development of a solid component warrants further histological diagnostic investigation. The management is guided, diagnosis and management is guided by estimation of the risk of malignancy based on the size of the patient. For the low risk lesion, in the low risk patient, the serial imaging carried out to assess the interval growth. For a high risk patient of a highly suspicious nodule, the PET CT or the biopsy can be undertaken. The Fleishner Society guidelines offer the specific recommendation, and these should be considered for individual patients. The risk of malignancy is low. The risk of diagnostic and therapeutic procedures is high, and the patient declines or unable to undergo the diagnostic procedure. The serial imaging is appropriate intervals is recommended based on the risk stratification. For high risk lesion or the diagnostic uncertainty, PET CT scan can be performed. Most malignant FDG AVID, which can influence the decision to biopsy, is given nodule or continue to monitor with the serial imaging. A small nodule and the indolent tumors such as minimally invasive or in situ adenocarcinomas, mucinous adenocarcinomas, and carcinoid tumors may have not adenocarcinoma. The mucinous adenocarcinoma or carcinoid tumors may not show the PET avidity. False positive results most often occurs in the infectious or inflammatory condition. The positive findings or the PET should prompt the additional workup. The non-surgical biopsy for the lesions that are high risk, enlarging, or serial imaging of uncertain diagnostic significance. Biopsy may be useful, and the typical modalities for sampling of lung cancer nodule include percutaneous targeted biopsies and bronchoscopic biopsies. Percutaneous biopsies performed by interventional radiology and the use of the imaging, either the CT or PET-CT scan to target the lesion of interest. Either FNA or core biopsy needles may be used. The CT-guided biopsy is most effective for the peripheral lesion and most common complications of the CT biopsy and hemorrhage and the pneumothorax, and the third of which are significant enough to warrant the chest tube placement. Bronchoscopic evaluation allows for direct evaluation for airways, which can reveal the external compression of the airway endobronchial tumor. Washing may be sent for cytology and direct biopsy and can be taken for mucosal abnormalities using uh, through the scope biopsy forceps. The radical ultrasound can be added to allow for endobronchial ultrasound guided transbronchial needle aspiration, EBS TBNA, mediastinal lymph node, as well as the pulmonary nodules that are in proximity to main airways and can be biopsied, and thus allowing for the staging and diagnosis to be completed at the same time. The diagnostic yield is screened and in utilization on the side of cytologist. The interpret adequacy of the sampling in the real-time sensitivity and specificity of EBUS TBNA vary based on the lesion location, size, and the user skill, but the over 90% in experienced hand. The traditional EBUS TBNA is limited to the central lesion and accessibility of the peripheral lesions, while the bronchoscopy has been augmented with development of techniques such as in investigational bronchoscopy, robotic bronchoscopy, and these techniques utilize within the bronchoscope to assess the lesion as far as the ninth generation airways. The lesion is located in the high resolution CT scan, and the operator follows either manually the greater or automated pathways to reach the target. With the robotic bronchoscopy and a stabilizing platform is utilized, which allows the exchange of the suction biopsy catheter as well as the precise manipulation after the identification of the target lesions using the imaging and the radial ultrasound. Surgical biopsies in the patient with high suspicion, malignancy, or the non-diagnostic attempt of percutaneous biopsy, definitive surgical biopsy can be employed, and this provides the histological access to the lesion of entirely. Frozen section can be used if the cancer is identified. The failure to recognize the lung cancer on chest X-ray is one of the most frequent causes of missing diagnosis in radiology. Rate of failure to diagnose ranges for 20 to 25%. The error rate is 20 to 50%. Surgery solitary pulmonary nodules are generally categorized as low, intermediate, high risk based on the radiological features. Low risk nodules of less than 6 millimeter in size, smooth borders, and occurs in the patient of less than 45 years old without the history of smoking and other cancers with COPD and asbestos exposure. Intermediate risk nodules are 6 to 8 millimeter size, lobular, and occur in the age of 40 to 60 patient. Those who smoke less than a pack a day or have quit smoking or have COPD. The risk lesions are more than 8 millimeter in size, speculated occur in more than 60 years of old and a personal history of the cancer, and those who smoke more than one pack a year and have a history of asbestos exposure. Lower moderate risk lesions, nodules can be followed with the serial imaging. Published guidelines, the high risk lesions or the lesions that exhibit growth during the follow-up period should raise the suspicion of cancer, and the additional diagnostic study, biopsy and resection should be considered. Thank you.